Hi everyone, it's another fine day that I want us to look at Nsaids in the management of pain, fever, and inflammation. But before we get into details of this particular presentation today, I want us to start by looking at the basic organization of the human being. The human being is organized in 5 steps. The first step is the atoms. Then from the atoms, we go to molecules. The molecules give us the cells. A group of cells gives us tissues. Then tissues give us organs. Organs give us systems. And then a group of systems gives us what we call the organisms. The organism, in this case, the human being. The human being. So examples of atoms, we have things like carbon. We also have oxygen. We also have hydrogen, among others. Examples of molecules, we can talk of water, and we can also talk of DNA. Examples of cells, we can have a nerve cell, can also have blood cells. Then we can also have muscle cell, among other examples. Tissues, we have 4 types of tissues. Those are epithelial tissue. And then we have the muscle tissue. We have connective tissue, connective. And then we have what we refer to as the nerve tissue. Examples of organs, we have skin. You can also have the heart. And then you can talk of the kidney, among others. Systems in the body, we have about 11 of them. Example is cardiovascular system and respiratory system. In the human body, we have about 7 octillion atoms. Octillion. Octillion is written as 7 raised times 10 raised to power 27. So we have 7 octillion atoms in the human body. The molecules are about 1 octillion, that's 1 times 10 raised to power 27. And then about cells, we have about 30. We have about 30 trillions cells in the body. That is 3 times 10 raised to power 12. Then we have 4 types of tissues. We have about 78 organs in the human body. Then we have about 11 systems. 11 systems in the human body. So this gives the basic organization of the human body. And therefore, I want us to look at the cell. And just to mention something, the cell has something we call the cell membrane. And in the cell membrane, we have proteins, we have carbohydrates, and then we have phospholipids. Phospholipids. So these are some of the structures that form the cell membrane. So the cell membrane has these components. We shall look at this component here when it comes to injury and how pain comes about. Therefore, we can say that there are three common symptoms that takes patients to the hospital. That is pain, fever, and inflammation. So those are the commonest symptoms that take patients to the hospital. Nsaids means non-steroidal anti-inflammatory drugs. Example include diclofenac, brufen, and indomethacin. Definition of pain is just an unpleasant sensory and emotional experience which is associated with tissue damage. Then when we talk about fever, this is an elevated body temperature which is above the normal range. So the normal range of the body temperature is 36.5 to 37.5. It can get raised, this range, in the event an individual has an infection or when you have inflammation. And therefore, what is inflammation? We are saying it's just a protective response. And this response is particularly to an injury or maybe an infection. And you need to know that inflammation can either be acute or chronic. When we talk of acute, it means the inflammation occurs rapidly and exists in less than 2 weeks. So if the stimuli persists beyond 2 weeks, then this inflammation becomes chronic. So we are saying acute is rapid and it's less than 2 weeks. If it persists beyond 2 weeks, then the condition becomes chronic. So this structure here, this illustration here explains how inflammation comes about in relation to the symptoms that we have mentioned earlier, that is pain, fever, and inflammation. So what you are seeing here, the whole of this diagram is an illustration of the events that happen in the body leading to inflammation, pain, and fever. So what you see up here is a representation of the cell membrane. In the body, we have cells and tissues. So when there is an injury to the cells, then the cell membrane has a component called phospholipids. We had mentioned earlier, phospholipids. Once there is an injury to the cells, an enzyme called phospholipase A2 will activate the phospholipids, and then they'll produce a substance called arachidonic acid. So it's from the arachidonic acid that all these other products come about. So once the arachidonic acid is produced, it can have two fates. The first fate, this arachidonic acid can be recycled back into the cell membrane. That is one. Another possible fate is that it will come down and it becomes a substrate for two pathways, either this one or this one. So there are two pathways here, this one and this one. So this pathway is what we call lipooxygenase pathway, that is 5-lipoxygenase. And then this pathway is what we refer to as cyclooxygenase pathway. So this pathway sometimes is abbreviated as 5-LOX, while this pathway The second one is normally abbreviated as COX. So, when we take the first pathway, this one here, the lipoxygenase pathway, and then this enzyme will activate arachidonic acid to produce LTF4. And then LTF4 can give any of these two products. That is LTC4 and LTA4. Under this enzyme we are calling LTC4 synthase. It can convert LTA4 into LTC, LTD, and LTE. LT just means leukotriene. So when you see abbreviation like LT, C or LT, D, that is 4 among others, it just simply means leukotriene C4, leukotriene D4, and so on and so forth. So we are saying that when we take the lipoxygenase pathway, then this enzyme will convert arachidonic acid into LTA4, that is leukotriene A4. And then these two enzymes can act on this substrate here. If LTC4 synthase enzyme acts on this LTA4, then we can get these products here. That is leukotriene C4, leukotriene D4, and leukotriene E4. And when it acts, when this enzyme called LTA4 hydrolase acts on leukotriene A4, then we get this product here, what we refer to as leukotriene B4. So these end products you see here, the leukotrienes, they have effect in the lungs. They cause what we call bronchospasms. So bronchospasms is a very common presentation in the patients that we refer to as asthmatic patients. And that's why we give medications called montelukast to actually block the effects of these leukotriene metabolites. Leukotriene B4 plays a role in chemotaxis, that is attraction of neutrophils to inflammatory sites. So that marks what happens when arachidonic acid takes the lipoxygenase pathway. So let's see what happens if it takes the COX pathway. There are two enzymes in the COX pathway. You have COX1 and COX2. What you need to know is that COX1, what we are referring to as cyclooxygenase 1 is an enzyme that is distributed all over in the body. That is COX1. But COX2, it is usually activated when there is an injury. So we can say without injury, COX1 is already present and it is functioning to produce prostaglandin products which perform what we refer to as housekeeping functions in the body, the functions that are beneficial to the body, and we shall see in the subsequent slides. So these enzymes, that is COX1 and COX2, activate arachidonic acid into prostaglandin G2, what we are referring as PGG2. And then from there, another enzyme called cyclic endoperoxidase converts prostaglandin G2 to prostaglandin H2. At this point here, there are three enzymes, this one, and this one. So what happens is, this enzyme here, what we are referring to as prostacyclin synthase, will convert prostaglandin H2 into prostacyclin. And then prostaglandin synthase will convert prostaglandin H2 into prostaglandins. And then thromboxane synthase will convert prostaglandin H2 to what we refer to as thromboxanes, and there are two. That is thromboxane A2 and thromboxane B2. So these prostaglandins have physiological functions in the body when activated by COX-1. And these metabolites, they have some significant clinical presentation in terms of fever, inflammation, and what we are referring to as pain, particularly when activated through COX-2, as we shall see in the subsequent slides. Thromboxane A2 plays a role in platelet aggregation and what we are referring to as vasoconstriction. So we shall see in the subsequent slides the effects of these metabolites, because after these metabolites have been produced, that is when we end up having the symptoms that we have mentioned as the commonest symptoms that patients present with. That is fever, pain, and inflammation. So this is the summary of that diagram, what we have talked about. That is step by step. There is cellular injury. That is after cellular injury, then phospholipase A2 is activated. That is an enzyme. Once it's activated, it converts arachidonic acid, which is released from the phospholipids, the structure I mentioned in the cell membrane. Once they are produced, these two enzymes, COX-1 and COX-2, that is cyclooxygenase 1 and cyclooxygenase 2, they will convert arachidonic acid, this one here, into prostaglandins. And then these prostaglandins, which is PGH2, that is prostaglandin H2, is converted by the tissue-specific enzymes into active prostaglandins. The active prostaglandins are prostaglandin E2, prostaglandin, this is prostacyclin 2, and then we have thromboxane A2, then prostaglandin D2, and prostaglandin F2 alpha. These are now active products that will lead to clinical effects that we have mentioned above. That is fever, inflammation, and pain. So this is a table to show the summary of functions of the metabolites we have mentioned about. This is leukotriene B, C, D, and E. Apart from leukotriene B, which leads to neutrophil chemotaxis, that is attraction of neutrophils to the site of inflammation, these other three, that is leukotriene C, D, and E, causes increase in bronchial tone, leading to what we call bronchospasm. What we have explained earlier. That's why we give montelukast to block these three, so that patients with asthmatic condition get relief. Then prostaglandin 2 decreases platelet aggregation. This one is found mostly in the endothelial tissues of the blood vessels. So it decreases platelet aggregation. Then prostaglandin E1 causes vasodilation. Prostaglandin E2 and prostaglandin F will increase the uterine tone. That is why we normally have uterine contraction whenever these prostaglandins are activated. Then thromboxane A2 will increase platelet aggregation and vasoconstriction. That is an important area, especially when it comes to drugs like aspirin that we give to inhibit the process of conversion of the arachidonic acid into the metabolites using the COX-1. We shall see in the subsequent illustrations. So this is another summary of the functions and effects of those metabolites that we have already talked about. And you can see prostaglandin 2 is the main custodian of causing inflammation, pain, and fever. That is when activated through COX-2. Then thromboxane is a potent vasoconstrictor and it stimulates platelet aggregation. Therefore, when you give aspirin, it blocks COX-1 that leads to production of this substance here, and the patient benefits, especially cardiovascular cases patients. We have seen leukotrienes, that is LTB4, that is leukotriene B4. It's a potent chemotactic agent which attracts white blood cells and increases vascular permeability to promote inflammation. Let's look at the major classes of anti-inflammatory drugs. There are 5. We have Nsaids, we have glucocorticoids, we have DMARDs, we have leukotriene pathway inhibitors, we have immunosuppressive cytotoxics agents, and then we have antihistamine drugs. And histamines are technically also considered as anti-inflammatory drugs because they inhibit histamine. Remember, histamine is one of the inflammatory mediators. The NSAIDs are just non-steroidal anti-inflammatory drugs. So maybe if we can revert back to our previous illustration, the corticosteroids like prednisolone, dexamethasone, and hydrocortisones, they act by inhibiting this enzyme here called phospholipase A2. So they work at this point here. Once they inhibit this enzyme, then it means all these cascades will not take place. So the corticosteroids work at this point here. They inhibit the phospholipase A2. Then the NSAIDs work on this route here. They inhibit what we refer to as the cyclooxygenase pathway. So they block this pathway here. Therefore, we cannot end up having these products which produce inflammation, fever, and pain. So let's look at NSAIDs particularly. We are saying they are just non-steroidal and inflammatory drugs. NSAIDs can be classified into 2. We can classify them based on the chemical structure. When we classify them based on the chemical structure, then we have salicylates. An example of salicylates is aspirin. Then we have propionic acid. Example is brufen and naproxen. Another category is acetic acid. Here we have diclofenac and indomethacin. Another category is oxycams. Here we have piroxicam and meloxicam. And then phenamates, we have phenamenic acid. And then causates, we have celecoxib. Another classification we can base on COX selectivity, and that is COX-1 selective, COX-2 selective. We have COX-2 selective inhibitors. They are highly selective for COX-2. So they inhibit COX-2 more than COX-1. So they select COX-2, meaning they only work on COX-2. They stop COX-2. Example of COX-2 selective inhibitors, we have celecoxib, eterocoxib, among others. Then we have what we refer to as COX-2 preferential inhibitors. These ones, they are non-selective, meaning they can inhibit both COX-1 and COX-2. But in this case, they inhibit COX-2 more than COX-1. An example of this category is meloxicam, diclofenac, among others. Then we have the non-selective in general. They inhibit both COX-1 and COX-2 in equal measures. Example of this category you have ibuprofen, indomethacin, naproxen, among others. So the low-dose aspirin, which is a COX-1 selective, it plays a role we refer to as cardioprotective role. So there are key differences and considerations you need to make here. In terms of safety profile, COX-2 selective inhibitors are associated with fewer gastrointestinal side effects, but they may carry a higher risk of cardiovascular events compared to non-selective NSAIDs. And then the mechanism is that non-selective agents inhibit both enzymes. That's affecting both inflammation, in this case COX-2, and gastroprotective prostaglandin, that is COX-1 and COX-2 inhibitors. So how does these NSAIDs work? They work by inhibiting COX-1 and COX-2 enzymes. Therefore, they reduce the conversion of arachidonic acid into prostaglandins. And therefore, non-selective NSAID, we have said they will block both COX-1 and COX-2. And selective COX-2, they inhibit just COX-2. And when you inhibit COX-2, you are targeting inflammation, which reduces GI toxicity. So that is the advantage of COX-2 selective drugs. Example of COX-2 selective, we have celecoxib and etoricoxib. Some of the adverse effects of inhibition of prostaglandin is that prostaglandin, particularly GE and GI2, they protect mucosal lining of the stomach, and therefore they reduce acidity. So when you inhibit these enzymes using the NSAIDs, the patient has a risk of getting ulcers and bleeding. That's why in patients with PUD, there is caution. You need to take caution in selection of these pain relievers. In the kidney, the function of prostaglandin is to maintain perfusion in low flow states. So when you give NSAIDs, they will block this function. And therefore, patients may be at risk of renal failure because of sodium and water retention. And therefore, NSAIDs are contraindicated in patients with kidney diseases. Function of prostaglandin in platelets is that thromboxane 2 promotes aggregation, that is, through the COX-1 pathway. Therefore, when you inhibit this function, the patient has increased risk of bleeding. And that is why patients who have high risks of bleeding, you are not supposed to use these NSAIDs. When we look at the function of prostaglandin on the first lecture, then prostacyclin, they play a role in antithrombotic processes. So, if you block this function using NSAIDs, then the patient will have increased risk of cardiovascular problems. In the lungs, the prostaglandin 2 dilates the bronchioles, that is in the lungs. Therefore, in sensitive patients, when you give NSAIDs, then this patient will be subjected to asthmatic problems, what we are referring to as NSAID-induced asthma. These are the clinical significance you need to take. That number one, low dose aspirin is irreversibly, it irreversibly inhibits platelets through COX-1. Therefore, low dose aspirin plays a role in cardioprotection. Then COX-2 COX-2 inhibitors, they are generally safe on stomach. That is, they don't have much effects, but they are not suitable in patients who have cardiovascular risks. So when you are selecting COX-2, they might be a little bit fair on the GI, that is gastrointestinal tract, but they have a high risk in patients who have cardiovascular issues. So a tip here is that you can combine NSAIDs and PPIs to reduce GI side effects in chronic users. But you need to avoid the NSAIDs in renal impairment patients or patients who have active peptic ulcerative diseases. So these are the clinical insights when you are using NSAIDs. Number one, in gastrointestinal risks, what you need to know is that NSAIDs, especially the non-selective ones, they can damage the gastrointestinal mucosa by inhibiting COX-1. Remember, COX-1 provides prostaglandin A, which plays a role in protective functions of the intestinal lining. So when you block it, patient will get gastritis, will get peptic ulcers, and they can get GI bleeding. So what you need to do as a clinical tip, you need to prescribe a proton pump inhibitor. Example is omeprazole, to reduce the risks whenever you are prescribing this medication. And then in COX-2, also the same thing. So that's why I was saying that prefer COX-2 selective. So a patient who has high risk of GIT problems, apart from prescribing PPIs, then you better prefer COX-2, because from COX-2, it doesn't affect COX-1, where the protective functions of the GI are regenerated. So COX-2 is fairly better in patients with GI problems. Another thing you need to know is that in renal impairment, NSAIDs can reduce renal blood flow by inhibiting the renal prostaglandins, especially in the elderly patients, dehydrated patients, and patients on diuretics or SCE inhibitors. This is angiotensin converting enzyme inhibitors. So what you need to do as a clinical tip is that you need to avoid these NSAIDs, or you can use them cautiously in patients who have CKD, heart failure, and hypovolemia. And whenever these patients are using NSAIDs, you have to monitor the renal function tests. Another thing we are saying on cardiovascular risk, long-term use, especially the COX-2, is not very good because it can increase the risk of hypertension, myocardial infarction, and stroke. So what you need to do, just use the lowest effective dose for the shortest duration possible. Then avoid in patients with recent cardiovascular events. So in patients who have bleeding risks, NSAIDs, especially non-selective ones, they will inhibit the platelet aggregation by blocking thromboxane A2. Therefore, what you need to do as a clinical tip, just avoid NSAIDs in patients who have high bleeding risks, or those patients who are on what we refer to as anticoagulants, or patients who are scheduled for surgeries. We still look at the clinical insights. In pregnancy, NSAIDs are generally avoided, particularly in the third trimester. because they increase a risk that we call premature closure of the ductus arteriosus. This is a blood vessel which is present in the fetus and it connects the pulmonary artery and the aorta. That is because in the fetal life, the lungs are not operational at that point. Therefore, blood is not directed to the lungs. That's why we have this artery, a blood vessel we are referring to as the ductus arteriosus. So whenever you give Nsaids in third trimester, then this blood vessel will do what we call premature closure and it will lead to complications to that fetus. So what you need to do as a clinical tip, if needed, for short term you can use in early pregnancy, but under medical supervision. That is not in third trimester, but in early pregnancy. So that is a caution that must be taken seriously. When we talk about drug interactions, then we are saying that Nsaids can interact with any of these drugs. When you give Nsaid with antihypertensives, then the effectiveness of your antihypertensives will be reduced. When you give Nsaids together with anticoagulants, then the risk of bleeding is increased. When you give Nsaids together with methotrexate or lithium, then there is increased risk of toxicity. So what you need to do in these cases, you must always review the patient's medications before you start these patients on Nsaids. So you can subscribe to our channel. We are present on YouTube, on Facebook, on TikTok, and the handles are the same. Our channel is referred to as Optics and Eye Health channel. Thank you. Let's meet in the next presentation.